I guess we're doing 2 videos in a day. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at cataracts. If you haven't yet subscribed to the channel, please hit the subscribe button. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment to show some support, as well as share the link to this page to a friend that is going through these things to help them learn these topics. Today we're going to be focusing pretty much on ophthalmology, and here's our warm-up question as usual. This is of course short answer questions. Answer the following question. Part A, define cataract, 2 marks. Part B, classify cataract based on etiology, 15 marks. What investigation will you do in a mature senile cataract with a visual acuity of light perception, that's what PL stands for, or perception of light, before you decide to do surgery? List the 3 types of cataract surgeries you know, 3 marks. So keep this in mind and we should be able to answer these questions by the end of the lecture. So before we actually go into talking about cataracts, it's paramount that we actually learn about the lens, because it will give some perspective to pretty much the lens. So remember that the lens is pretty much this transparent structure. It is biconvex in shape or in structure, and it is crystalline in appearance, and it's just going to be found in between the iris, which is the colored part of the eye, and the vitreous, okay, which is pretty much providing the nourishment. So remember that the lens is right at the center, dividing the anterior segment of the eye into an anterior chamber or an anterior chamber of the anterior segment and a posterior chamber of the posterior segment. That tends to confuse a lot of students. I know you're probably even lost in the video, so let me just show you a black screen here so that I can actually explain this concept very well before we actually move on. So suppose we look at this well-drawn eye that I'm about to draw on your screen. Ignore the art that is so good that I should have actually joined art school. But anyways, so we have this as our lens here, okay, and we have this here as our iris, which is of course an extension of the uveal tract, the middle part of the eye. Then of course here you have our lens and our suspensory ligaments over there, and we'll have our suspensory ligaments over there. So imagine that this is an eye to some extent. So this, everything behind the lens here, we refer to this as the posterior segment. That's what I was trying to explain. Then everything in front of the lens is referred to as our anterior segment over there. So this is the posterior segment of the eye. This is the anterior segment of the eye. Then the anterior segment is further divided into an anterior chamber, which I shall call AC, and it's divided into a posterior chamber, which I shall call PC. So you have an anterior chamber, you have a posterior chamber. You have an anterior segment with these 2 chambers and a posterior segment of the eye. That's what I was telling you about, the division that's actually taking place. So this lens is actually going to be held in place by these suspensory ligaments of the lens, or the zonules of Zinn, or you can call them as the ciliary zonules, which are pretty much attaching to the ciliary body and the equator of the lens. Now these suspensory ligaments are going to be composed of a protein that's known as fibrillin. Now remember that the lens doesn't have any blood vessels. It is avascular, so it's pretty much going to be deriving its nutrients from the aqueous humor. Remember that the aqueous humor is a fluid that's going to be found in the anterior segment of the eye, both in the anterior chamber and the posterior chamber of the anterior segment. Then of course, one of the functions of the lens is for accommodation, which is really much a property, one of the properties of the lens. So remember that the power of accommodation varies with age. So at birth, it's roughly somewhere around 14 to 16 diopters. Then at 25 years, it's about 7 to 8 diopters. Then at 50 years, 1 to 2 diopters. So it tends to, the eye's ability to accommodate actually tends to decrease as you grow much older. When you grow even very, very old, you lose the ability to accommodate and you have a condition that's known as presbyopia. So remember that the lens is pretty much going to be composed of 64% water, 35% proteins, 1% lipids, carbohydrates, and trace elements. And of course, the lens is elastic in nature, but it gradually loses its elasticity as you grow much older, which is another reason why even the accommodative power tends to decrease as you grow much older. I already mentioned that the lens is actually avascular, so there's no need to beat that point to death. Now remember, when you are talking about problems that are pretty much going to be affecting the eye or the lens to be specific, they may affect the structure of the lens, they may affect the shape of the lens, they may affect the position of the lens. Now, the lens itself participates in anaerobic respiration. So glycolysis is responsible for pretty much 85% of the glucose utilization by the lens, and it actually results in lactate formation. So a few properties about the lens: it has a refractive power of 1.39, it has a diopteric power of 15 to 18 diopters, or accommodative power. It has a diameter of 9 to 10 millimeter, and of course a thickness of 4 millimeters. The radius of the anterior surface is 10 millimeters, so this is less convex, it's more flat. Then the posterior is the one that's actually more curved, it's more convex, so it's about 6 millimeters, and it weighs roughly around 250 milligrams, and it grows progressively. From birth, weights about 65 milligrams, and at 80 years approximately about 258 milligrams. You should actually know some of these values because they do ask you these things, especially on MCQs, because it's a nice thing to test students on. So here's the structure of the lens. As you can see here, we have the anterior pole, which is pretty much less curved, and a posterior pole, which is more curved. And then of course we have the center here, which is the equator. You have the sutures, you have the capsule that is surrounding the lens. Of course, this is the side view of the lens, this is an anterior view of the lens. Now, what are some of the parts of the lens? So you have a capsule, which is going to be surrounding the lens. So this is going to be thin, it's going to be transparent, it's going to be thick anteriorly, and it's going to be thin posteriorly. So you have a thick part, which is in the anterior aspect, and a thin part at the posterior aspect. On the anterior side, you have an anterior epithelium just underneath this capsule. Now, this epithelium is going to be consisting of cuboidal cells, which lie deep to the anterior capsule. And in the equator, or the center of this lens, they actually become columnar cells, and they are actually actively dividing, actively elongating the lens. And actually, these are responsible for how the epithelial cells are pretty much going to be growing out from this area. So there is no posterior epithelium, so the epithelium is actually in front. At the back, there is no posterior epithelium. And of course, these cells are used to fill up the central cavity of the lens. And you have a cortex, which lies pretty much between the capsule of the lens and the nucleus of the lens. So this cortex is pretty much going to be consisting of fibers, lens fibers. Keep this in mind, keep this anatomy in mind, because it's going to be very important when you talk about cataracts. Then of course, the nucleus is the central part, and it's going to be having 4 nuclei depending on the stage at which you are. You may have an embryonic nuclei, which is pretty much found between 1 to 3 months of gestation. You may have a fetal nucleus, which is pretty much 3 months to when the child is born. And then you may have an infantile nucleus, which is birth to puberty. Then you have an adult nucleus, which is pretty much early adult life. So here's another picture reminding you that the lens is made up of the capsule, lens epithelium, anteriorly only. You have the lens fibers, and then you may have zones, the cortex, or the anterior cortex, the equatorial cortex, and the posterior cortex. Then of course the different nuclei depending on the age of the patient. Now, what are some of the functions of the lens? One is to maintain its own clarity and transparency. Remember, like the cornea, the lens is pretty much transparent. It's going to be transmitting 80% of light between the wavelength 400 nanometers to 1400 nanometers. The second thing is that it's going to have this refractive power to the optical system that's there in the eye. Then 35% of the refractive power of the eye is actually offered by the lens. It also functions in the process of accommodation, especially for near vision, as well as absorption of harmful ultraviolet light. So this is some of the functions of the lens. Now we'll come to cataracts. So now, way back before science was actually well advanced as it is right now, people used to think in a different way, or rather the same way. When you think of it and look at it now, it kind of sounds very dumb, but that's because they didn't have much to work with. So way back, they thought, or the thinking was, that you had some abnormal fluid, kind of like how a waterfall is. If you've seen a waterfall from the front, it appears to be covering the entire mountain or cave that may be behind. So that's a similar analogy that was used to talk about cataracts. Initially, people thought that there is some abnormal fluid that's pretty much flowing in front of the eye, in front of the lens, and pretty much obstructing the vision or decreasing the vision. So that's why the word cataract is actually coming from the Greek word cataractes. I don't know if I say that right, and this actually means waterfall. So the word cataract is coming from the waterfall. So it's actually an incorrect depiction of actually what is happening. But now that science has actually evolved, we now see that the problem is actually with the lens and not really in front of the lens. So cataracts is actually the most common cause of treatable blindness in the world, and its incidence actually increases with age. We get about 1 in every 2 patients that are older than 75 have cataracts. So it means 50% of everyone that's above the age of 75 has cataracts. So the present definition of cataracts actually is pretty much came into the light when we got to understand the anatomy of the lens and how the anatomy works, and the lens being normally transparent. So now we can define a cataract pretty much as development of any opacity in the crystalline lens or its capsule. So it's pretty much an opacity to the crystalline lens or its capsule, which may either be congenital or developmental, or it may be acquired. So the same opacity can form congenitally or developmentally, where the child is actually born with it, or it may be actually due to a degenerative process where you have this opacification of the normal lens due to an acquired condition. We'll talk about these conditions. Though clinically, the term cataracts is just any opacification of the crystalline lens or its capsule with sufficient severity to impair vision. That's going to be our clinical depiction or a clinical definition of a cataract. So here's what a cataract looks like. How I know that this is a cataract, as you can see here, it's within the pupil. Okay, you can see that this pupil is very wide. You would ask me, why is this pupil wide? And I want you to answer the question in the comment section below. I'm very interested to know why a patient with cataracts would have a quite wide pupil like this. Okay, I will pin the comment that gets the answer correct at the top of the comments, of course. Then of course on this side here you have the normal eye, so you can see that this is pretty much covering the iris, or rather the pupil, not the iris, within the iris. It's not really on front of, or it's not found in the cornea, it's not overlying. So what is the classification? So it may be classified etiologically, which is the classification I would want you to know, and it may also be classified morphologically, depending on the location where the cataract is. So etiologically, it may be a congenital, developmental, or hereditary, meaning you're born with it, or it may be acquired, meaning it's a condition that develops over time. Now, according to morphology, it pretty much depends on where you find this cataract. It may be capsular, subcapsular, cortical, supranuclei, or even polar. I will show you images a bit later on. So we'll talk about congenital or developmental cataracts. So these are pretty much in genetically susceptible individuals, and they are associated with certain chromosomal patterns. So they are inherited in certain families. So they are often present at birth or occur early in childhood. They are usually stationary, so they are not progressive. They're not in most cases, but they may be progressive rather. Sorry, correction about that. They may be progressive. In most cases, they are not progressive, but they will be progressive, meaning that they will get worse. Then, of course, 2/3 of them are going to be bilateral. So in 2/3 of the cases, you have cataracts affecting both eyes. In 1/3 of these cases that are congenital are hereditary. Another 1/3 are due to infections or congenital syndrome. Then 1/3 are idiopathic. So 1/3 of them are hereditary, 1/3 of them are infective or congenital syndrome, another third are idiopathic. Then the most common inheritance pattern is an autosomal dominant pattern. Then of course there are some familial cataracts that have been seen. Now the symptoms that are pretty much going to be pointing you towards cataracts is of course leukocoria. This is the sign that I've actually shown in the previous diagram. This sign here is known as leukocoria. Okay, so keep that in mind. So you're going to be seeing this leukocoria with an absent red reflex. Remember that the red reflex is going to be like the pupil always appears red when you are looking at it through a lens. So if you actually take a picture, and if with those old cameras that have turned off the red eye setting, or even in your camera, if you turn off the red eye setting and you take a picture, you realize that your eyes are actually going to be appearing red right within the pupil. It's going to give you that red appearance, but you lose that red reflex, especially in children that have cataracts. Then of course it may be unilateral or bilateral. You may have nystagmus, you may have strabismus or squint. Then of course the child may be unaware of the surroundings, especially if it's bilateral. Now all children who have leukocoria should have a slit lamp microscopy examination as well as a dilated fundoscopic examination. This should be performed by an ophthalmologist to ensure that the cataracts is the diagnosis. And of course the morphology of the cataracts also can give you some insight on the possible cause. And of course you're going to have a diagnostic workup. So you're going to be doing your routine labs, your FBCs and all those things. You want to screen for torch infections. So you want to screen for toxoplasma, rubella, CMV, syphilis, and then of course you want to do your urine for amino acids, phosphate, calcium levels like in Lowe's syndrome. Now congenital causes, remember 25% of them or a third of them are hereditary. So the inheritance pattern is autosomal dominant. Then of course they may be due to maternal causes like maternal malnutrition, and as in zonular cataracts you may have maternal infections like the torch infections, especially in the first trimester where organogenesis is taking place. It may be due to drugs like corticosteroids, exposure to radiation. Then fetal causes, it may be due to deficient oxygenation due to severe placental hemorrhage like a placental previa, a birth trauma. Metabolic disorders are very, very important in this case. So the fetus may have things like galactosemia, you may have galactokinase deficiency, you may have neonatal hypoglycemia, you may have Lowe's syndrome where you get this urine, calcium, phosphate and amino acids. You may have Alport syndrome, which is also associated with hearing impairment. It's also associated with renal defects. It's also an X-linked condition. You may have Fabry's syndrome, which has this characteristic skin lesions. You may have renal impairment. You may also have an X-linked disorder, it is an X-linked disorder. Then of course you may have Coats disease, which usually tends to present unilaterally and presents in a much older child where you get this gradual loss of vision. You may have some common chromosomal abnormalities such as Down syndrome, trisomy 21. Even malnutrition can be some fetal causes that may result in congenital cataracts. Then of course it may be idiopathic, so you may not really know what is causing the cataract. Then of course the acquired causes may be due to senile cataracts. As you're getting older, this is the most common cause. There may be traumatic, there may be complicated cataracts, there may be metabolic cataracts. Diabetes is one of the things that comes to mind. Remember, hypertension does not cause cataracts. Why do I say so? The lenses are vascular, and hypertension usually affects the blood vessels. The lenses are vascular, so you shouldn't code hypertension as a cause of cataract. Then of course you may have electrical cataracts, radiational cataracts, toxic cataracts, for example with corticosteroids, some mitotics induced cataracts, copper, iron induced type of cataracts. It may be associated with skin diseases, which is referred to as dermatogenic cataracts. They may also be associated with osseous disease with the bones. You may also have some other syndromes like dystrophica, myotonica, Down syndrome, Lowe syndrome, and so on and so forth. So here's a diagram giving you the congenital developmental types of cataracts. Here, of course, they have grouped them into different types based on the morphology, I presume. Punctate cataracts, zonular cataracts, coronary cataracts, anterior capsule cataracts, posterior capsule cataract, and then other forms of cataracts. Then, of course, acquired are senile, cataracts associated with ocular diseases, cataracts associated with systemic diseases, cataracts due to radiant heat or other energy, traumatic cataracts, and then after cataract. Then, of course, morphological classification pretty much depends on the part of the lens that's affected. Remember when I was telling you about the parts? So the cataract can actually affect the capsule anteriorly or posteriorly. You have an anterior capsular cataract, a posterior capsular cataract. It may sometimes just be underneath the capsule, so it involves the superficial most part of the cortex just below the capsule. So it may be anterior again, subcapsular cataract, or posterior subcapsular cataract. It may affect the major part of the cortex. You call that as a cortical cataract. It may be involving the deeper parts of the cortex. You call that as a supranuclear cataract, just above the nucleus. Then you may have a nuclear cataract, which involves the nucleus of the crystalline lens. You may have a polar, which is pretty much going to be involving the capsule and the superficial part of the cortex in the polar regions only, and this may be an anterior polar cataract. It may be a posterior polar cataract. So this is pretty much based on the morphology, and here are the different locations that are actually shown of the morphological shapes of the cataract. So some of the risk factors that may be associated especially with senile cataracts: advancing age, cigarette smoking, diabetes, hyperlipidemia. Hypertension is a risk factor. It's not a cause. So hypertension, why? It's because hypertension may also result in high levels of other things that may predispose an individual to developing senile cataracts. Because remember that, anyways, I'm not even going to go into that detail. I just want you guys to keep in mind that it is a risk factor, not a cause. Then, of course, hyperglycemia as well as ultraviolet exposure. Now, what are some of the clinical features? So symptoms, which is pretty much what the patient is going to be feeling. There will be painless loss of vision. Remember, painless. Comparing cataracts with glaucoma, remember that cataracts are painless. Loss of vision. Glaucoma, painful loss of vision. Okay, so painless loss of vision. You may have visual impairment, so you may have a glare, which is just simply an uncomfortable or dazzling bright light or intolerance to bright light. You may have clouded vision. You may have colored halos, especially yellowing of the vision. You may sometimes have these black spots in the front of the eyes and image blurring. In some instances, there may be actually changes in refraction. You may have a myopic shift where the patient actually uses reading glasses more often. Then, of course, you may have monocular diplopia, which is double vision that usually does not go away when one eye is covered. So if you cover one eye, you're still having double vision. And of course, in infants, cataracts may actually cause a amblyopia, which is a failure of visual maturation. You actually deprive the retina of a formed image at a critical stage of visual development. Infants with suspected cataracts or family history of congenital cataracts should actually be assessed by an ophthalmologist shortly after they are born, because this is a matter of emergency. Then, of course, the signs: you may get leukocoria. There are many things that do cause leukocoria. You should have at least 10 differentials for leukocoria, and I want you to list them in the comment section below if I haven't given them in this PowerPoint presentation. Then, of course, you may get reduced visual acuity. In some patients, you measure this in a dark room. They may be satisfactory, but if the same test is actually carried out in a bright lit room or in sunlight, then their acuity fails, and because of this flares and because of this loss of contrast. And also, the small pupils in bright light may restrict light entry. Then, of course, the cataracts appears black against red reflex when the eye is actually examined directly with a direct ophthalmoscope. There is a black opacity against a red background. And then when you perform a slit lamp microscopy, you may actually identify the location of the cataract, then in the detail of the cataract. So with the age-related type of cataract, they are common in the nuclear, cortical, and subcapsular locations. The steroid-induced are usually subcapsular. Then, of course, there may be some pigment deposition of the lens, suggesting previous inflammation or damage to the iris, suggesting previous ocular trauma that you may actually see. Then congenital cataracts is usually associated with other conditions like nystagmus, strabismus. So like I've mentioned, here are some of the differentials for leukocoria: retinoblastoma, retinal malformation, retinopathy of prematurity, persistent hyperplastic primary vitreous, retinal detachment, and even intraocular infections. So leukocoria in a child is always considered as a medical emergency, and an ophthalmologist should actually examine this child. Then Even though some cataracts may be reversible potentially, as they mature, they will remain, and the lens is actually going to be irreversibly thickening. So a mature cataract, the patient actually is not going to be able to read, so they have a visual acuity of 20/200, and the patient is actually said to be legally blind. And of course, with the immature cataract, the patient can actually see better than 20/200, but they cannot see better than 20/20, so they have clouded vision. Then of course, an incipient cataract, the patient cannot see 20/20, so they have subclinical cataracts. If you have no idea what these numbers actually mean, we will release a video on visual acuity and how it's done, and pretty much explanation of these numbers, so please just stay tuned to the channel. Then what's the diagnosis and investigation? So pretty much we want to perform a clinical assessment. So we want to take a history, we want to perform an ocular examination, you want to perform slit lamp microscopy and fundoscopy. Remember that these are not investigations, they are clinical assessments. Then of course our investigation is going to be our ultrasound B scan, and then of course other investigations are pretty much going to be dependent on the underlying cause. Our differential diagnosis includes things like macular degeneration, presbyopia, retinal detachment, as well as vitreous hemorrhage. Now, what's our management? So remember that treatment of congenital cataract, surgical removal should be no later than 3 months of age. So most infants with these congenital cataracts are at risk of actually subsequent cataracts. So regular follow-up with ophthalmology should be done. And of course, you should consider genetic counseling wherever appropriate, because there is association with some chromosomal abnormalities. Then of course, the much more effort has been directed towards slowing the progression or even preventing the cataract, but the mainstay management is surgery. The medical management is pretty much going to be addressing the underlying cause. If it's diabetes, address the diabetes. Then surgical management, the R types of surgery, they may be intracapsular cataract extraction or extracapsular cataract extraction. So in intracapsular, where you use this technique where you're going to be having the entire cataractus lens is going to be removed along with the intact capsule. So remove the lens and the capsule. Then in the extracapsular cataract extraction, the majority of the anterior capsule with the epithelium, the nucleus and the cortex is removed, but we leave behind an intact posterior capsule. So here we're leaving behind an intact posterior capsule. In the other procedure, we're not leaving this behind. Then of course, you may use some techniques like phacoemulsification. This is ultrasound fragmentations. You may have conventional extracapsular cataract extraction. You may have manual small incision cataract surgery. But of course, there is no need to wait for the cataract to actually ripen or to cause any visual loss. You can actually even operate on these individuals before this happens. And of course, the tests as to whether or not the cataract produces sufficient visual symptoms to reduce the life of quality. Of course, that would warrant immediate treatment. Then of course, prior to surgery, the patients must be informed of any coexisting eye diseases which actually may influence the outcome of the cataract surgery and the visual prognosis. Now, some complications include vitreous loss. You may have iris prolapse, so the iris may actually protrude through the surgical incision. This is actually an immediate complication, and it's going to be appearing as a dark area at the incision site, and the pupil is going to be distorted. So this requires immediate surgical repair. It's also one of the surgical emergencies. Then, or ophthalmological emergencies. Then you may have endophthalmitis. I don't know what's wrong with my pronunciation today. So patients are actually going to be presenting within a few days of surgery. They may have a painful red eye, they may have reduced visual acuity, and of course a collection of white cells in the anterior chamber, which is known as hypopyon. Then of course you may have cystoid macular edema, you may have retinal detachment, as well as opacification of the posterior capsule. Now, here is our warm-up question. So define a cataract. So this is a development of an opacity in the lens or its capsule, either due to the formation of opaque lens fibers, which is congenital or developmental, or due to degenerative processes, like for example, acquired cataracts. Then the classification I will show you on the next slide. Then the investigation that we must do in a mature cataract, of course, we want to do an ultrasound B scan where we want to detect any retinal detachment or any vitreous pathologies. Then of course, the 3 types of surgeries that we can do: intracapsular cataract extraction, extracapsular cataract extraction, which can either be a phacoemulsification, which is usually used on its own or classified on its own, conventional extracapsular cataract extraction, as well as manual small incision cataract surgery. Now here is the classification according to the etiology. So this is developmental or congenital versus acquired type. Remember that the congenital may be due to certain infections affecting the fetus, certain other problems affecting the mother, and of course the acquired as listed below. I really hope you enjoyed learning about cataracts. If you did, please drop a like in the video or on the video, and please hit the subscribe button and the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, share the link to someone who is doing ophthalmology and to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye bye.